I'm Avital Havusha. I'm the Vice President of Programs here at the newly modified name NYHealth Foundation. Before we get started, I want to just put out a few housekeeping items and then we'll jump into the content. We'll be recording this webinar and a recap will be available soon after. We'll share the slides and other materials of interest. The video and audio are disabled for attendees, but we do invite you to use the chat box to share comments and questions throughout. We'll be having dedicated time for questions and answers for the second half of the presentation. So please keep your eye out for that. And also we do have a closed captioning feature available at the bottom of your screen. There's instructions in the chat there if you need to use that. So I just wanted to kick us off by setting the stage a bit and introducing our really wonderful guests that are here today, experts in the field. As you all know who are joining us today, prior to the pandemic starting, depression and anxiety among young children and adolescents was already at a 2-decade high, with 20% of adolescents suffering from diagnosable behavioral health disorders. And the onset of the pandemic, with children facing school shutdowns, sudden shift to remote learning, educational loss, social isolation and fear and trauma related to loss of a parent or caregiver, those issues have only been compounded. And we all know also that there's the compounding stress and trauma in communities, among schools, parents, and students related to horrific racially motivated events like last week's mass shooting. And many children are really facing a mental health crisis. So as a result, as we know, the demand for psychological services are at an all-time high, especially among school children. And the return to in-person learning has really sparked an increased need in those in-person services as children struggle with exacerbated mental health issues. And while schools and parents and children had hoped that maybe as classrooms reopened, the challenges with distance learning might fade away, it's become clear that the past 2 years are really have some ripple effects that are playing out in schools. And so school-based health centers, which you'll learn more about today if you don't already know already, are really of one of the places where we're addressing these challenges here in New York. Of course, there's immense need and school-based health centers only have limited resources, but they really have been at the center of the response. And so we're so lucky to have our speakers here today who will talk a bit more about how school-based health centers have really been set up and are now using a capacity building approach to address these issues in schools and in school communities and with community partners. So we have a lot of content to cover, so I want to make sure I introduce our presenters and get us going. So our experts today are Rhonda Cuddlechuk, who's the chairman of the board of the School-Based Health Center Foundation, Scott Bloom, who's a former director of mental health services for the New York City Department of Education, Lisa Perry, who's the manager of the New York School-Based Health Center Foundation's Behavioral Health Program, and finally, Julie Blitzer, who's an outreach and prevention psychologist at New York Presbyterian School-Based Health Center Program. So we're so lucky to have this panel of experts. I want to first turn it over to Rhonda, who will get us started, giving us a little bit of context about the School-Based Health Center Foundation, and then the rest of the group will walk us through a brief presentation, and then we'll have the second half of the session to really dig into some questions and discussion. So Rhonda, I'll turn it over to you.
Thank you, Avital. I'm Rhonda Cuddlechuk. I am the chair of the board of the New York School-Based Health Foundation. We are a 501c3. We work hand in hand with the New York School-Based Health Alliance, which is the advocacy organization for school-based health centers. Our mission is to strengthen, promote, and increase access to New York State's 266 school-based health centers. This is a wonderful occasion to share with you one of our 3 programs. This one is on behavioral health. We do one on telehealth, and we also have a project putting together a statewide repository, information repository on school-based health centers. So we're delighted for this occasion. Thank you, Avital, and I will now turn it over to Lisa.
Thank you, Rhonda. Are the slides up?
I think we'll just, if everyone give us just a moment, we're going to get those slides shared for you.
Great. Wonderful. Thank you. So welcome to our presentation, School-Based Behavioral Healthcare in a Mid-Pandemic World. We're going to be talking about the New York State School-Based Health Foundation's program to strengthen capacity to meet the needs of students. Next slide, please. So I want to start off with an acknowledgement of the funders who made the program possible. Both the New York Community Trust and the New York Health Foundation have funded our 2-year program to strengthen the capacity of school-based health centers to deliver behavioral health care to the students of New York State. This program would not be possible without their support, and we're grateful for these 2 funders for their understanding of the importance of this work and their vision and trust in us. Next slide, please. A very brief program overview. As I said, it's a 2-year program. We are serving 10 different sponsoring organizations each year. A sponsoring organization is a healthcare provider, an FQHC, a medical center, or other provider organization that operates school-based sites. So we are serving 10 sponsoring organizations and their sites. Altogether, they have 70 sites, the 10 that we are working with. Our grant year runs from January through December, and our goal is to enhance the capacity of these school-based health centers to respond to the growth and need that grew out of the COVID-19 pandemic. So for those in the audience who may not be familiar with school-based health centers, we have a very brief 101 here. It's a healthcare provider site located within a school in an underserved, low-income neighborhood. SBHCs provide care to the school's students and in some cases, members of the surrounding community. The sites provide medical, behavioral health, and dental care and are frequently a student's only source of health care. They're operated by hospitals, federally qualified health centers, and other licensed healthcare organizations known as sponsoring organizations. Throughout New York State, 47 sponsoring organizations operate 266 sites, serving 250,000 students in both urban and rural areas. About 2/3 of the sites are in New York City, 1/3 upstate. But of our 10 sponsoring organizations, we have a slightly higher representation upstate, over 40% in the Buffalo, Rochester, and Cooperstown areas. Next slide, please. Briefly, the program that we are running consists of the following benefits for our participating organizations. Each organization has a bank of 10 hours of customized individual technical assistance with our subject matter expert, Scott, to make plans and address priority issues of their own sites. We've also, about 2/3 of the way through our educational webinars. We have our next one will be coming up in the fall. We've had webinars on the school as client and also on suicide prevention to date. We have we're building a web-based resource library that's available through our website. The URL is on the last slide of the presentation. Each sponsoring organization received a startup stipend through the grant for an improvement project that they design in consultation with the program. We'll be reporting on quantifiable outcomes and offering a session at the School-Based Health Alliance's annual conference. So I think now I am turning it over to Scott.
Hi, can you hear me? Great, thank you, Lisa. Yeah, so why is mental health at school-based health centers, right? As we know that there are many positive outcomes in schools by having mental health services on site. Too many positive things to mention here today, but I just wanted to highlight a few of them for you. It certainly increases resiliency and help-seeking behavior. Research shows that by having mental health on site, parents don't miss a day's work and kids don't miss school, which are important for the parents and important for our school administrators. It's a lot of improvement in using decision-making, problem solving. Students are getting social emotional learning skills, positive interactions with others, and it decreases mental health stigma because, as you'll hear in a moment, some of the programs and projects that are being done in our program, it's to promote mental health, and that help is available for you on school, during the school day, after school programs. And what that does, it makes fewer referrals based on challenging behaviors, because the idea is to try to get the help at an earlier stage before it gets intensified. You'll see decreased referrals for special education, students in restrictive environments. You'll see a lot of disruption from class time and school activities. And that's real important for principals. They want to know that kids are getting more class time, more instruction time. It's one of the challenges we'll talk about in a moment, and certainly improved academic achievement. And this is something becomes a win-win. A secondary gain here is that teachers have more confidence when they take workshops, when they get trained in the school, and that confidence then comes out in the school classroom, so that better classroom management and better understanding of what a mental health problem is and what a mental health problem isn't. Just to give you, Avital talked a little bit about the pandemic and the impact it's had. This will just give you some youth mental health trends that we're starting to see. Particularly the percentage of youth has doubled in the past decade. 50% of mental health conditions began before the age of 14, 75% by the age of 25. Most folks probably know by now that suicide is the second leading cause of death for youth and children. And only roughly half of white youth and 1/3 of Black and Latino youth with depression receive treatment. We know that by the numbers, we know there's been an increase with youth that have identified as LGBTQ. We know that there's been an increase in the Black population, particularly in youth, for depression and suicide ideation and contemplation. So again, we're probably preaching to the choir a little bit, but it's important to understand right now the state of mental health for our youth across the state. The United States Department of Education came up with a list of recommendations because of COVID, because of what they're seeing for the impact of COVID. And I just want to go through these fairly quickly, because I think you'll hear that some of the projects that we're doing in this program addresses some of these needs. Certainly prioritize wellness for each child, student, educator, and provider. So it's really the school community. It's not just the student here. Again, we talked about reducing stigma and other barriers. We know that in many cultures and in many families, getting mental health help is still a stigma, and we're trying to break that down in the schools. Implement a continuum of evidence-based prevention practices. That's when we talk about treatment, whether it's CBT, DBT, using motivational interviewing, and a lot of trauma-informed best practices in the schools. Establishing an integrated framework. And this is really has to do with the collaboration between the mental health providers in the school-based health centers and the academic world. Sometimes they kind of butt heads, but what we're trying to do is integrate it so folks see that academic needs are also mental health needs, and mental health needs are also academic needs. And we can go into that later if you'd like. Certainly leveraging policy and funding, as this project is helping with. Enhancing workforce capacity. We're going to talk about that because there's a real shortage in getting professional clinical help in schools. And of course, using data for decision making and promoting equitable implementation of outcomes. You have to show the data. Schools want to know if what you're doing is working, why it's working, and where it's working. So that's important to keep schools abreast of the outcomes that you're seeing. So for those of you who don't know, what are some of the challenges in providing mental health in schools? For all the multiple years that I've been doing this work, schools are a separate beast. They really are a world unto their own, and there are lots of challenges. Again, we talked about staffing and training, talking about community coordination, either with mental health agencies, external community-based organizations to come into the schools, and also for the folks who are already in the schools. Delivery, do you take a kid out of instruction class for them to be seen by the health center for mental health? Are there ways of working that out? And certainly a lot of school coordination, money, time, and privacy. There are FERPA laws for our school settings, and then there are HIPAA laws for our health centers. And so every year we have to go through those so that both the school administration and the health centers understand what they can and can't say and what they can and can't do. These, we can go into lots of details, but I just want to give you a flavor. It's very different than working in a hospital or an outpatient clinic where you just see somebody for 45 minutes and that's it. In a school, lots of other barriers and challenges that health centers have to overcome. One of the ways of framing working in a school, particularly for mental health, is thinking of the school as a client, right? And just as we do for anyone who's going to an outpatient clinic for mental health services, we want to know what the presenting problem is. And that with each school, we want to know why they want our services. What are the major issues they're seeing? What are the barriers to access to services? What have they tried? What didn't they try? And that becomes like an assessment. So when we see a client, we're also doing an assessment. We may do a screening. We may do an evidence-based screening to see about depression and anxiety. It's the same thing we're doing with a school. What is the temperature of that school? In New York City, there are 1,800 schools. Each one of them is a world unto themselves. And just because you have one school down the street from another doesn't mean that they're always doing the same things here. So we have to assess and what we would call a kind of gaps or mapping of the resources, internal and external. And then just as a client, you do all of that, you come up with a treatment plan as how to approach the problems and the goals that you have. And it's the same thing with the school, that you want to say, okay, let's try these 3 things within the next 3 months, 6 months, and a year. So we may have short-term, midterm, and long-term goals. And that's the way you'd want to do it with each of the schools that you're in. And finally, and this is one that's not talked enough about, I think, is what I call learning the language, learning the culture. Each school is very different. In each school, there are some schools you walk into and you kind of get the vibe that they're welcoming, they appreciate that you're there, they work with you and do what they can. And there are other schools you walk into and there's chaos, there's pandemonium, and that's on a good day. But there are also so many things that can go on and happen in schools. And we want to make sure that we're speaking sort of their language. So we have to get them. You can go into a principal's office and it's clean and pristine and it looks like a CEO. That's the way you have to address them. And then you can go into a principal's office and it's chaos all the time. It's every few minutes, there's something going on. There's an emergency, there's a crisis, and it never stops. So you have to be able to work within that, as I say, the language of that school. And certainly the culture of the school. Is it predominantly Hispanics, Latino? And where? Is it the Dominican Republic? Is it from Mexico, from Guatemala, or San Salvador? Those cultural issues, as an example, are important to understand and important to know on how to work with, respect, and be part of that school system. So the way that we frame it is using a public health model. So some of you may be very familiar with that. And we use a 3-tiered model for the school. So just like if you had tuberculosis, universal means everyone can get a TB tested. And then selective, there are some people who are going to need a TB shot. And then targeted, some people actually need to be quarantined. It's the same thing in the schools, just to give you an idea. Universal, meaning that these supports are open to everybody in the school. They promote, when you think about promoting mental health campaigns, workshops, trainings, referral sources, anti-bullying campaigns, universal. It's about 75% of all the kids will just need those kinds of resources and activities. And then we move up the triangle to selective. These are supports aimed at intervening early for children who are at risk for abuse, for neglect, for dropping out, at risk for a more intensive type of intervention. So the ideal work here is peer support, group work, restorative practices, restorative justice, and some crisis interventions, right? Not everybody gets it, not everybody needs it. And this is typically 15% in any school. And then finally is the targeted services, and that's when you have your DSM-5 mental health interventions, you have your evidence-based practices, and many health centers are able to do individual, family, and again, some group work, psychiatric involvement if need be, psychiatric assessment or psychotropic medication. So how does that play out in our program? Well, I'm giving you a little bit of a taste here to see where some of our SOs are doing their work. Universally, we see that a number of agencies are getting youth mental health first aid training so that they can in turn train and turnkey that training to the paraprofessionals in the schools, the nurses, the deans, the APs, and for teachers. Some agencies are doing school-wide screenings so that they can detect, identify, and refer kids who need services before they become intensified. Others are doing mental health awareness campaigns, focusing on LGBTQ youth, or partnering with mental health agencies within the community. On our selective side, some of our projects include Shedding COVID, which is actually a wonderful mind-body intervention. So it has to do with self-image, weight loss and maintaining weight, strengthening themselves, as well as looking at self-esteem issues and depression and anxiety. Others include stress reduction groups, resiliency building groups, and expressive art groups. Again, all of those in that selective area for kids who may be dealing with emotional and other kinds of distress. And finally, there are a few agencies that are going to be doing EMDR, which has to do with trauma. And rapid eye movement is an evidence-based treatment dealing with traumatic situations. And DBT, dialectic behavioral therapy, and you may be hearing about some of that in a little bit. So what I think what you can see from the project is we're not using a cookie cutter approach. We're really asking each of the 10 SOs to pick one specific area that they want to work in this year and that we would support them. The wonderful thing is we do have one of our presenters and one of our projects here, Dr. Julie Blitzer from New York New York Presbyterian Hospital. She works at the School-Based Health Center, and she's going to talk and give you a little bit of a flavor of the project that they are doing. Julie?
Thank you, Scott. Thank you, Lisa. Again, my name is Julie Blitzer. I'm the Outreach and Prevention Psychologist at New York Presbyterian School-Based Health Center program. Thanks for having me, you all. And I want to do a special thank you to the New York School-Based Health Foundation for awarding us this important grant. And thank you all for being here to find out a little bit about our project. Just a little background on our program. Our school-based health network consists of 7 sites. We serve about 7,500 students in Upper Manhattan and the Bronx. We're a very diverse population of students, and the majority of our students are high school students, so adolescents. We have some middle schoolers and a very small amount of grammar schoolers, so we mostly serve adolescents. For this project, it was our goal to come up with something that would maximize the support for our mental health clinicians. As you know, we're all pretty short-staffed at these clinics and in outpatient clinics as well. while also advancing some clinical innovation in our settings. So we chose to focus on EMDR, and I'll talk to you about why we chose to focus on that. A little bit about what EMDR is. It's eye movement desensitization and reprocessing. It's a mouthful. Maybe some of you know what it is and some don't. It's gotten a lot of traction lately in the last, I would say, 10 years. It's well researched at this point for treating trauma-related symptoms in people of all ages. It involves sort of focusing on negative thoughts and feelings related to traumatic experiences. While keeping that painful experience in your mind, the clients will sort of engage in bilateral stimulation, which is eye movements and also some forms of body tapping in order to process through the emotions related to those negative experiences. So that's sort of the concept. What our goal is to provide our program's mental health clinicians with consultation groups led by an experienced EMDR practitioner and trainer through at least all of the next school year or a portion of the next school year. So why did we choose EMDR? There is a very practical reason to this, which is that the majority of our mental health staff were trained or are being trained in EMDR through free training from the Department of Mental Health and Hygiene. There is just a high level of trauma-related pathology experienced by our student population, unfortunately, some having to do with COVID and others for other reasons. Even pre-COVID, there was a very high level of trauma-related pathology. There's a real need for targeted guidance for clinicians on implementing EMDR in different settings. It's often used in a private practice setting. Ours is not a private practice setting. There's a lot of other variables. So we wanted to get some targeted help with how to adapt EMDR in a school-based setting with children and adolescents. Also, we obviously wanted to get support around culturally responsive adaptation of EMDR, especially since our population is extremely diverse in the New York City area. So what are we going to do? How are we going to get this done? The idea is to do monthly or bi-weekly groups with all of our clinicians who have been trained or are being trained on how to implement EMDR in our setting. There'll be a lot of case presentation. It'll be heavy on case presentation, we're envisioning. We do at this point think we have that person who's going to provide this for us. So that's a really good step in the right direction. As Lisa and Scott mentioned, we're going to track it and report and get some data on students who need this kind of intervention. We're also going to implement a screening protocol to help target the students who need them. So, and gather some data in that way. We are also going to monitor the needs of our clinicians very carefully. We'll do a lot of check-ins in addition to the groups. And sort of meet the challenges of implementing in our setting. Also, this is sort of the universal intervention part of things, but we want to be able to increase community awareness, students, parents, the schools, about what EMDR is, and that it is an effective treatment. It's a little different, and I think it's perceived as a little strange by some when you first sort of talk about it. So we need to sort of make people comfortable with this idea. And so that's our general plan. We're extremely excited to have this opportunity, and we'll get started rolling it out in September. So thank you all, and take it away, Lisa.
Thank you, Julie. This is our contact information. If anyone has any questions that don't get answered during the program, feel free to contact us. And at the bottom of the screen is a URL for our website where there's a lot more information about the program. I think I'm turning it over to Avital now to monitor the Q&A. Great.
Thank you all so much. That was so informative. You've left us, I'm sure, with lots of questions, but also a lot to digest and reflect upon. So I really appreciate you setting us up for a great discussion. As I said before, feel free to chat any questions, and I'll be keeping an eye out into the chat, so you can chat us through there. And in the meantime, I'm going to kick us off with a few questions to get us started. to dig into some of the issues that you started to raise. So I think I'll start with kind of going back to the framework that you laid out, and then kind of Julie spoke a little bit about how you're adopting one portion of the framework. So having that universal, selective, targeted approach, of course, with the targeted approach being the most intensive support. And you also alluded and mentioned many times this idea of the kind of crisis in terms of both the students, but also the stress on the workforce, that there's a real strain in terms of the number of providers available and the capacity of the providers at this point to take on new clients. And so I'm just wondering if you could just speak a bit more to how schools are maximizing some of those partnerships and collaborations to try to balance out some of those resource strains, especially to, kind of distribute their work through those more universal activities, and then still conserve some resources for the more intensive and targeted work.
Yeah, well, I can certainly start there, Avatal. I think part of it goes back to when I mentioned sort of an assessment process like you do with a client. I think you need to do the same thing with a school. Again, I've done hundreds of school visits, and one school can have all the resources in the world, and you just go 2 blocks away and they don't have anything. So part of it is helping them to leverage what they have. Sometimes it's just bringing to them, they don't know that what the state might offer or what the local district might offer in terms of services, activities, resources. So you want to start to leverage that. Sometimes you find in a school that people are doing duplicate work, and it's one of the worst places to do duplicate work because it's so intense and it's so fraught with busy work. So you want to make sure that everyone knows their roles and their responsibilities. One of the things that I'm a big proponent of is being proactive versus reactive. I think that if you create some of these universal interventions, which have to do with anti-stigma campaigns, knowing where to get help, giving teachers and school staff the tools to do quick, identifying if a child is it a discipline problem? Okay, well, there's a certain protocol for that, but is it a mental health problem? And not all discipline problems are mental health problems. I have hundreds of stories of social workers being brought in. That's not their job. So a lot of it has to do with increasing capacity for schools to understand what are the signs and symptoms of mental health and how to address those proactively before things get worse and before things start to blow up. And I think by doing more of those preventive work early on, you'll see less and less people kind of move up the triangle.
Great. Thanks. I don't know if anyone else, if Julie, if you wanted to jump in on that at all in terms of how you've seen it play out in your schools.
Absolutely. I agree with all of what Scott just said, especially being able to talk to schools about free resources that they may not know about. I'm thinking about the Let's Talk campaign, the Department of Health. It's wonderful training, but I noticed that, some schools didn't know about this. And then once we were able to discuss it and I gave a brief intro to it, they took advantage of it. So sometimes it's just about disseminating the information. There's a lot of, I think, silos that happen with certain systems. So, mental health staff at school-based health centers can be helpful in assisting with that. I have the honor of actually being able to focus on prevention and outreach. Like that's my job. I know a lot of school-based health centers don't have a psychologist or anyone doing that. So I was over the pandemic able to do a ton of webinars and a ton of outreach. We do, campaigns on things like sleep or healthy relationships. We've done a tabling event that, helps students understand what the school-based health center is while also having a little bit of fun. We did that outside recently. So those kind of events and campaigns, I think, go a long way. It's hard to quantify exactly. But I think if any clinic can start doing that in the capacity that they're able to, I think it can be really helpful. And I've collaborated a lot with my mental health staff without overburdening them with the obligation of having to do like, the actual work of creating the presentation. I say, hey, come on, just do this with me, present with me so they see your face, right? And they know who you are. So there's a lot of versions of how, mental health staff can actually do this outreach work without feeling overburdened.
That's helpful. And, I'm going to get you a question in the chat in a minute, but I wanted to build on just Scott's comments and Julie's comments about kind of that targeted needs assessment work. So I know, just digging into that a little bit more, I know that some of the schools you're working with have kind of identified needs to think about needs assessment in a different way, and to maybe they've noticed something as they've started this work with you all. They need to understand something more about their students or their local partnerships outside the walls of the school. So can you maybe speak a little bit more, maybe an example or two of how schools are kind of embarking on some of that needs assessment work, and what tools are they using to do it? Or they might just be kind of leveraging what they already have, but curious to hear a little bit more about that.
Sure. Well, one of the groups is Bassett Health, and they've been, they're actually, as we speak, have put together a group of various stakeholders within the schools so that they can do a SWOT analysis, right? Looking at the strengths, the weaknesses, where the trauma, where is that going to be sort of their comfort zone, and where and getting out of their comfort zone. So they're getting together some therapists, some non-therapists, stakeholders, and really sitting down and kind of rolling up your sleeves, so to speak, so they can come up with an analysis that will look at what are the needs. You go into schools and sometimes they want, but often they don't know what they need. They'll say, oh, we need 5 crisis workers. Then you look at the data, and the data shows actually your crises have been down. You guys have been doing a great job with it. And so by sitting down, listening to each other, finding out again, what are you overlapping? Where are you working too hard? Where are you working too hard? Again, because you're being reactive rather than proactive. You're not taking the time. So I think they're looking at that, and they're going to be putting together a result and take it from there. And I think that's the next step of bringing us into it, saying, hey, okay, now we're coming together now. We want to, be able to for you guys to help us to take the next steps. There are some of the other projects, they realize team building, because they're working, Julie mentioned before about silos. And this is a wonderful thing to break some of the silos. I'm working with school nurses, I'm working with nutritionists, I'm working with the school-based health centers, and I've got my mental health partners, and I have so I have 6 different silos, 6 different visions, 6 different missions. So I want to be able to bring them so we all have one vision, and that's to help kids overcome psychological barriers to academic achievement. It's a pretty good common thing. So those are some of the kinds of assessments that folks are doing.
That's helpful. Go ahead, Lisa. Yeah.
About the Bassett example.
Yeah, sure.
Was motivated by the severe shortage in behavioral health staffing that everyone's experiencing, but particularly in a rural area. So they're really trying to explore alternative ways of delivering behavioral health care to their students, whether it's through their primary care providers or possibly partnerships outside. So it's kind of a universal challenge that everyone's facing, and that was their approach to it.
Great. Oh, that's helpful. And I'm sure a lot that they'll be able to share with others once they do that analysis. And Lisa, my question might actually follow up on that. One of the questions that came in through the chat is how schools were identified to partner with you all. I think this is obviously you have capacity to do some level of technical assistance, but maybe you could speak a little bit more to, obviously this is a smaller program, but what resources might be available either coming down the pike or in a next phase of work. Oh, you're on mute.
Muted. Sure. I mean, we recruited from among organizations that were running school-based health centers. So we're not actually partnering directly with schools. We're partnering with our school-based health centers who partner with schools. So any organization that operates a designated school-based health center site in New York State is eligible to join us in our work. We will be recruiting a new round of 10 organizations starting in January. So I'm happy to speak with whoever raised the question and see if they might be eligible. But also we are building our online resource library, and our webinars are open to everyone. They are publicized on our site. We have a calendar. So if you go to that URL, those are resources we can offer to everyone.
Great. And we'll make sure that for everyone who's listening in, we'll make sure to share all of that in the recap as well. So you will have direct access to all of those pieces of information. So then maybe circling back a little bit to some of the needs in the schools, I know, and the kind of the cohort of participants that are currently working with you. I know you did some specific site surveys about the needs and capacities within each of the schools participating. Scott, you shared some really sobering statistics about the overwhelming need that we're seeing kind of writ large. But I'm curious if maybe you could speak to some particular things that stood out in those more site-specific surveys too, either around need or capacity.
Well, as I mentioned before, and this is across the country right now, the demand for mental health services is probably at a all-time high. At least that's being promoted and being in social media and newspapers, and folks are finally, I think, taking it more seriously than they have before. But the supply is very low. And as some of them are doing is, again, so staff shortages was, I think, our number one across all 10 of the SOs, and really looking particularly by the needs of the referrals that are coming up. So I think one of the things that people are looking on is, again, trying to identify better identification, better focus, that this is a real mental health problem, and trying to prioritize it. So some folks are looking, can they, what we call, task shifting? Are there non-clinical folks that can help with these kinds of surveys, referrals, using those kinds of tools to identify kids, and then those that really need the help go to the clinicians that are available. A lot of them talked about maintaining resources. That was a big one. As we know, the minute we've learned the hard way, the minute you print something in paper, it's probably outdated. So as Lisa was talking about and Rhonda was talking about, creating an electronic resource repository that has all these, the information there, and there's some great apps. So we're letting folks know about that. And I think also the mental health activities, reaching, dealing with the culture. Again, who's coming to the school? Who are those communities in the school? And I think that's really important, and sometimes it's forgotten. Are they newly arrived immigrants? Where are they from? What health disparities has your community? What's been the impact of the health disparities because of COVID? Right, food, clothing, shelter. It's death of a lot of caregivers, parents, loved ones. So that kind of grief, therapy that's needed, the bereavement that's needed. So we really kind of looked at some of those larger issues that are hitting the schools. So that's some of them.
Thank you. I don't know if anyone else wants to jump in on that. If Julie, are there specific things that Scott didn't touch on that are specific to your schools?
I was gonna say, it can feel daunting to need to put into effect all these formal ways of measuring something. In my position, I basically sort of just started to send out Google surveys to school leadership and certain school staff that I knew would be responsive, just to get a sense of what's happening at their school. So I asked the same questions to all the schools that we serve. We serve 21 at this point, over 7 campuses, and just take that feedback as a start of a conversation about what we can help them do in this sort of more prevention capacity. Another sort of informal way that we try to get involved is just being at meetings, even if we're not invited to them, sort of inviting ourselves to Zoom meetings with the principals or assistant principals, the safety meetings at the schools, town halls, things like parent meetings, where you really get a feel of what's going on without needing even to ask direct questions. We do a lot of pushing into meetings, just saying like, hey, we're here, we're the school-based health center, we got a couple slides, we're just going to talk for 2 minutes. But it also gives us a chance to absorb what's going on at the school. So it doesn't have to be always a super formal way of assessing what's the needs. I do think one more thing, that the schools, there's a big push for SEL in schools, right? And that's wonderful. And I think that was intensified when COVID came around, when schools realized they needed to support their kids more holistically. And so in those SEL curriculum, there's usually pretty good ways of assessing like what's going on at the school and what the school's needs are. So I haven't dug into it, but I'm hoping schools have gathered that information and then they can kind of share it with us and say, hey, maybe you could help with this part of things, or, you know, this is what we found has been really difficult. So hopefully the schools are formalizing that way of assessing their needs.
Yeah.
If I could, I would take a lesson from what Julie is saying, because most of the schools aren't going to go to you and tell you that. So you have to go to them. In many cases, you are the, you are the impetus for them to, oh, right, that SEL thing we got, and we have to do, oh, right, we have. So it's a way of getting them to say, hey, we should be part of that planning. Many schools have a comprehensive plan, a crisis plan, a plan of action. They may call it something different in each district. And somewhere in that plan, you as a school-based health center, particularly if you have mental health, should be part of that plan. There's no question about it. You should be part of that. So sometimes, as Julie's saying, inviting yourself to meetings. Hey, did you guys do the crisis plan yet? We're here to help. Let's go. Let's do some role play. So that integration, as I was mentioning before, between academic and mental health really becomes intertwined.
Great. Thanks. So that's a really helpful context. And just Scott, tying back to what you had said about some of the needs within specific communities and emerging needs in communities. Of course, it's hard to ignore what last week's horrific tragedy in Buffalo and racially motivated mass shooting. But then, of course, just the general culture of hate crimes and mass shootings in schools, which I can only imagine how much trauma and stress that causes among students, parents, school communities. Can you speak a little bit more to how events like that really impact schools on the local level and addressing that stress and trauma among their communities?
Yeah, that's a great point to bring up, and that should be opened up to everyone here. I think the first thing, like many of our mental health organizations across the states have been saying, first of all, we shouldn't conflate violence with mental health. That's a real misnomer, and it's a real misunderstanding about what mental health is. I'm not here to be political or opinionated, but we need to understand that as kind of a foundation and a bedrock. Simply, as I was saying earlier, some things are a discipline problem, and they're restorative practices, restorative circles, and some things are a mental health issue. So we have to understand those two things. The second thing is, and you were alluding to it again, even on a local level, what happened in Buffalo, the threat of violence, discrimination, racial, it's happening all over the country, and it's going to have a psychological impact on our students. And our students want to talk about this. They want to talk about it. And we know that we read there are some states that don't want to, or cities, but it's important. So you have to have that ability for teachers to be trained, could be on implicit bias, understanding, again, what is mental health, what are the signs and symptoms. Again, increasing that capacity makes it a positive environment for everyone to be, again, more proactive than reactive. Julie was talking about SEL, social emotional learning, and it's important to have those conversations. So, because you're keying into kids' decision making, problem solving, and they don't want to be seen, to be kind of pushed under the rug, or we're not going to talk about it. Schools are a place of learning, and this is something to learn about. How to be with each other, particularly after COVID, when so many kids are also, dealing with social anxiety. So, I'm kind of tying a few things here about the racial disparities, the economic inequalities. Let's call it what it is, and let's try to have, meaningful conversations for teachers and for kids alike.
Thank you, that's helpful. And, I know we're kind of running into our last few minutes, so I just want to invite anyone else who has questions to please feel free to share them with us. I think one of the big questions I have that I think, given what we just spoke about in terms of the level of resource needs, and Scott, you just alluded to even, even branching out in terms of social emotional learning, in addition to some of the services that school-based health centers might be providing. There's clearly a number of gaps in terms of resources to be able to really address all of those elements that you described and these challenges. So I would just want to open it up a little bit to hear if you have some ideas about what are some of the recommendations that might be on the table around filling some of those resource gaps. Are there policy examples that are out there or solutions, maybe some bigger, some smaller, but I'll open it up to see if any of you have any thoughts on that space.
Well, I might just speak at a high level
Sure.
with regard to school-based health centers. Unfortunately, they enjoy a long history of underfunding, and many of them are limited in their administrative capacity to respond, to come forth with initiatives. We will be in a meeting. Very, very often, the clinician is also the administrator. So we'll be in a meeting, talking about some important subject, and a child with a crisis will walk in and they'll say, please excuse me. So the foundation and the Alliance have a very important agenda of trying to call attention to how wonderfully placed these organizations are to address a whole host of issues, and how investment now in young people is likely to have a lifetime impact, positive impact. So that's at the policy level with regard to Medicaid, to the state, to all the funding sources. And it's one we bump up against every day. We can say, wow, this is a really terrific program. What if we offer this to our school-based health centers? And it's like, one more thing. So it's very much our objective to get them out of that situation and to have them paid adequately for their services.
Lisa, were you going to jump in as well?
Yeah, Rhonda and I spoke about this.
Okay, yeah.
There are issues around, more technical issues around reimbursement.
Right.
A lot of the things that we're talking about, like universal interventions, group work in many cases, for many providers is not covered by Medicaid, and is such as I understand from our experts, a powerful mode of treatment for adolescents. So funding is inadequate in that regard. There's also some direct grant funding to the school-based health centers that just covers a fraction of the need. They're serving uninsured children every day, and there is no compensation for that.
And let me add on to that.
Yeah.
They play a very important preventive health role. You can think of these as public health entities as well as healthcare delivery entities. And it's no news to probably anybody here that those activities are very poorly funded. The things you would do at the classroom level, the things you would do at the school-wide level. And those are often the most impactful in terms of particularly the kinds of problems we're talking about today.
Absolutely. No, that's really helpful. And I'm not sure if Scott or Julie, if you wanted to jump in on this at all at the kind of local school level.
Yeah, there was, I think with both Lisa and Rhonda are talking about, there was a point where the State Office of Mental Health was looking at some kind of hybrid for schools, which would allow for that. Some looking at day treatment programs where you have assigned social workers and they can go into the classroom, right? Because that's part of it. We're working with the state ed. That kind of folded, don't know why, but having some some hybrid and understand the model, understand how schools work. Often there's, the public presentation of things, and then there are best practices. And you have a group of folks here, and I'm sure in the audience, who understand best practices, understand how schools work. I think it is, with advocates, getting them to understand so they can pay for those. Otherwise, what happens on the local level is that, they offer some enhancement, some funding or discretional funding to try to help them balance so that they can hire enough staff and keep them going. So there's opportunity out there, and I think we have some of the answers. It's getting the right people at the table.
Yeah, absolutely. So it seems like, since we're closing up, that thought seems like a good one to close on, in terms of knowing that a lot of the work that you're all doing right now is going to continue to generate a lot of best practices that we can be sharing with the field, sharing with some policymakers around potential for replication, sustainability, expansion. So we're looking forward to reconvening with all of you soon as you continue your work. For those of you in the audience, we'll of course be sharing all of the resources from today, including some of the resources that we've referenced throughout on the School-Based Health Center Foundation's website, so people can access those, and we'll make sure you have contact information for our presenters if you have other questions and want to dig in further on any issues. So with that, I really just wanted to thank all of you. This has been so informative, excellent conversation about, a really hard and difficult issue. And I really just appreciate all of the work you're doing with your school-based health center partners to try to address it. And we're looking forward to continuing the conversation in the coming months.
Thank
you.
Thank you so much.
And to everyone in the audience, thank you for joining us. We'll be circling back soon with that recap, and feel free to continue to check out the New York Health Foundation's website for other upcoming events throughout the early summer. And with that, we do wish you all a lovely rest of your afternoon, and thanks again for joining us.